Rotator cuff disease. Rotator cuff. It comprises the tendinous insertions of four muscles. The four muscles are supraspinatus, infraspinatus, teres minor, subscapularis. Together, the cuff functions as a mass depressor of the humeral head. Supraspinatus muscle. Origin is supraspinatus fossa of scapula. Insertion, greater tubercle of humerus. Innervation, suprascapular nerve C4 C6. Function, initiation of abduction of arm to 15 degree at glenohumeral joint. Stabilization of humeral head in glenoid cavity. Infraspinatus muscle. Origin, infraspinatus fossa of scapula. Insertion, greater tubercle of humerus. Innervation, suprascapular nerve C5 C6. Function, external rotation of arm at glenohumeral joint. Stabilization of the humeral head in glenoid cavity. Teres minor muscle. Origin, lateral border of scapula. Insertion, greater tubercle of humerus. Innervation, axillary nerve C5 C6. Function, external rotation and adduction of arm at glenohumeral joint. Stabilization of the humeral head in glenoid cavity. Subscapularis muscle. Origin, medial 2/3 of the subscapular fossa. Insertion, lesser tubercle of the humerus. Innervation, upper and lower subscapular nerves C5 C7. Function, internal rotation of arm. Stabilization of humeral head in glenoid cavity. Mnemonic. Rotator cuff sits on the shoulder. S for supraspinatus, I for infraspinatus, T for teres minor, and S for subscapularis. Rotator cuff disease. The spectrum of the disease ranges from impingement syndrome to massive degenerative cuff tears, mainly age-related tendinopathy. Acute traumatic cuff rupture is rare, about 1 to 3%. Impingement syndrome. A rotator cuff impingement is a type of injury that causes shoulder pain. It affects the muscles and tendons between your arm bone and top of your shoulder. An impingement happens when one of these tendons is injured, causing it to swell and get pinched by the bony top of your shoulder joint. The pinching makes it hard for the blood to flow through. Doctors sort these injuries into 3 grades based on your symptoms and how much damage the impingement causes. There are total 3 grades of the impingement. Grade 1, swelling and inflammation. Grade 2, tendinopathy or weakened tendons in the shoulder. Grade 3, tears in the rotator cuff or changes in the shoulder bone, such as the growth of bony spurs called osteophytes. Clinical features. Age 40 to 60 years. Poorly localized pain over greater tuberosity and deltoid area. Unable to sleep on the affected shoulder. Painful arc 60 to 120 degree. Able to maintain power in all muscle groups when pain abolished by local anesthetics. Neyer's test. What is Neyer's test? It is a common test in orthopedic examination of the shoulder. It is used to test for subacromial impingement of rotator cuff tendons. The test is very simple to conduct and is quite reliable. Starting position. The test is best performed with a patient in a relaxed standing position. The arm to be tested should be moved passively by the examiner. The patient's arm of the shoulder to be tested is positioned such that the arm is relaxed at the side of the body and elbow is fully extended. Test movement. From the starting position, the examiner internally rotates the patient's arm and forcefully moves the arm through the full range of forward flexion or until reports of pain. Positive test. The Neyer's test is considered positive if pain is reported in the anterior lateral aspect of the shoulder. Rotator cuff tear. A rotator cuff tear is a common cause of pain and disability among adults. When the rotator cuff becomes injured or torn, it is described as a rotator cuff tear. These tears may be classified as partial thickness tears or full thickness tears. A partial thickness tear is the term used when the tendon is not completely torn. A full thickness rotator cuff tear is the term used when the tendon is completely torn. Clinical feature: age more than 40 years, poorly localized pain over greater tuberosity and deltoid area, unable to sleep over the affected shoulder, difficulty lifting arm and carrying, trick movements to shorten the lever arm and reduce the load on the cuff by keeping the hand closer to the body, may progress to the rotator cuff arthropathy. Radiological features: glenohumeral and axillary view may be normal. Sclerosis of the undersurface of the acromion may be seen. Sorsal eyebrow sign. Late cuff disease: humeral head rises breaking the Shenton equivalent line of the shoulder. Ultrasound: high resolution ultrasound is excellent in detecting small and medium sized cuff tears with greater sensitivity than MRI in experienced hands. Ultrasonography is also useful for accurate placement of injections, that is subacromial, glenohumeral or acromioclavicular joint. MRI, the current gold standard, but can give false positive results for cuff tears in pure impingement. Management: there are two types of management. Number one is non-operative and number two is operative. Non-operative management: subacromial injection of steroid and local anesthetic, physiotherapy to strengthen or maintain the remaining cuff muscles, analgesia, glenohumeral injection in massive cuff tears. Operative management: subacromial decompression, that is either arthroscopic or open, repair of the rotator cuff, that is open or arthroscopic, debridement of the rotator cuff, arthroscopic but no repairment. Shoulder replacement: for cuffed arthropathy, failing non-operative treatment, possibly with a reverse polarity delta shoulder. Thank you.